Another moment or two. We're just gathering. Welcome. We'll just wait another minute as folks join. I think we've got a quorum now. So welcome, everybody. If you're online, you are online with the Operations Committee meeting. Today's August 28th, and we are going to start the meeting with a roll call. Isabel, you ready?
I am. Hi, everyone. So Bruce Goldberg.
Present?
Thank you. Judy Richardson.
I'm here.
Thank you. Ann Lovejoy. I see you, but I don't hear you. If you're able to unmute.
That's the other key piece of the roll call, is to see who we can hear and not hear. Maybe let's come back to Ann.
Okay. Doug Flo. I do not see Doug in today's list. Laura Byerly. Do not see Laura today. Rosalind Lindsay. Do not see today. Michael Horry. Do not see. Doris Karagu.
I'm here.
Hello.
Thank you. Sarah Fucci.
Yes, it's Fouché.
Jay.
Boucher, I'm sorry.
No
I've
problem.
mispronounced that twice now.
problem.
Thank
I'm
you.
here and I'll be able to get on video in about 10 minutes.
Okay, thank you. Paula Weldon. I don't see Paula. And Lori Hoagland.
Here.
Thank you. That's everyone.
And Ann, do we?
Can you hear me now?
Yes,
Yes.
I can hear you now. Thank you, Anne.
Great. So welcome to the meeting. We have a packed agenda, as people have no doubt seen. We're going to the major parts of our meetings today will be understanding how PEB and OEB administer their plan. I think will give us some good background as to what operations could look like. We've got the Milliman folks with us and to talk about the work that they're going to do. We've got a presentation on 1331 and 1332 waivers. And we're going to talk about the whole issue of regional operations. So a packed agenda. And with that, I'm going to turn things over to Mimi, who will give us a little bit of background into what the other committees and the board have been up to.
Thanks. Good afternoon, everyone. Thank you so much for being here. I'm Mimi McDonald, the Executive Director of the Universal Health Plan Governance Board. So just with a brief update, first I'll tell you what the board is up to. We had a board meeting last week. A large portion of the meeting was dedicated to discussing revenue strategy. That was not a formal proposal, was not brought forth, but just different revenue options to help fund what would be considered a funding gap for the Universal Health Plan. And that's definitely still a work in progress with a lot of information coming in. The board did approve a primary care provider payment proposal. So that was good. That was accepted. That had been put forth by Plan Design and Expenditure Committee. The other thing that the board was discussing, which is going to be brought up here today, is sort of how a regional entity might function within the larger structure of a universal health plan, an independent public corporation. So I think the discussion today is going to be really relevant, and I know the board will want to hear more about that. In terms of our Finance and Revenue Committee, they have, as I mentioned, been working on revenue strategy. They have another meeting next week. And I think that out of that, the plan is to get some sort of a proposal to put forth to the board on just a preferred some preferred options. Other work that's happening, Echo Northwest will be working on the impact of that revenue plan sort of on individuals and households. And then our colleagues from Milliman are also just starting to develop what will look like an impact on Oregon as a whole, sort of a larger picture of what would happen with the state when a universal health plan is implemented. Plan design and expenditure, as they said, they put forth that primary care payment proposal. They have also a packed agenda this next week. So there are mechanisms, behavioral health payment systems. The other things I forgot to put on this list, they're looking at emergency transportation, and then again, looking at quality strategies. So they're working hard in putting together proposals. And last but certainly not least, our community engagement and communications committee has done tremendous work, a lot with the help of Patty Wentz, who just has been phenomenal. So they have put together a strategic messaging guide just yesterday. Some of the materials that they have created were approved by the CECC. So there was a one-pager, sort of a simpler one, and then a much more detailed one that they approved, and those will be going to the board, or they recommended to go to the board, and those will go to the board for final approval. Still pending are a sheet of FAQs and then sort of a final PowerPoint. The other thing that CECC is working on is working on those engagement meetings, getting together with groups of different types of people within Oregon to get their feedback on where UHP is at currently with the plan, and for some information about going forward. So I wanted to ask Bruce and Judy, any other things you wanted to chime in from the board standpoint? Oh, I know, Bruce, you weren't there, so I guess just Judy, sorry.
No, I think you covered it well.
All righty, thank you. Okay, so for this, there was something that came that as an update to the operations work plan. So there should be an attachment that is available with the invitation, or if you go on the regular website. But the main changes to this operations work plan, so this was the one that was created sort of in mid 2024, kind of before this committee was completely formed, but describing what the charge and what the deliverables were for this operations committee. The main thing that's changing about this work plan is we're hoping to have you all work a little bit longer, so apologies for that. But so changing the timeline from this committee's work finishing in December 2025 to finishing in February of 2026. Things just took a little bit longer than anticipated. The other thing that happened was just a little bit of clarification of the deliverables. So I'm not going to read through these. It's, again, essentially the same as what had been there previously, but just a little bit of clarification. So as we move forward, and this is a way for the board to kind of check on, like, yep, checking it off, that this is what the operations committee said that they were going to do, and this is what they've been able to deliver for us. So I'll take a second and see if anyone has any questions about that. If there aren't any questions, I'm going to ask if we would be able to have just approval from this committee to move it forward to the board. The board will give final approval on this official work plan update. So Isabel, would you mind doing a roll call again?
And do Bruce Goldberg,
Yes.
Judy Richardson,
Yes.
Laura Barley is absent, Doug Flo is absent, Sarah Fouché,
Thank you. Yes.
thank you, Lori Hoagland,
Yes.
thank you, Michael Horry is absent, Doris Karagu,
Yes.
thank you, Rosalind Lindsay is absent, Anne Lovejoy,
Yes.
thank you, and Paula Weldon. Looks like Paula might have
Oh, it looks like they may have dropped off.
dropped
I
off.
don't see their name on the list.
Okay,
All right, thank you everyone so much.
Okay, thanks, Mimi. And next we have Cindy Bowman, who's going to talk to us about PEB and OEB and how they operate in essence, their self-funded business. Welcome, Cindy.
Well, hello, everyone. Hopefully you can hear me.
Absolutely.
I am going to do my very best to go through this. There's a lot to do with operations within PEB and OEB, so I do have some slides. I am an expert in some areas and not so much in others, so I fully anticipate that I may have to take some questions back with me and get you some answers. I have with me Margaret Smith Issa. I see she's on. She's going to help me. I know one of the questions in the preliminary conversation that I had with some of you had to do with performance guarantees. So she is truly our expert on that. So I asked her to come along and talk about that. She also works with the PEB and OEB boards and also their work groups. And so I think she can give you some good background on that. So I will share my slides. I'm also opening up notes for myself. So I'm going to try to do it all at once and move through the slides too. So just stop me. I'm hoping it can be more or less an informal conversation. So I want to focus on what you're really interested in learning about. So I'll move through some slides quickly. If you want me to, stop and concentrate on something, then just let me know. Okay, so first figuring out how to share in Zoom. Okay, are we there?
Perfect.
You can see it.
Yes, absolutely. Thank you.
All right. Hopefully you're not seeing my notes version. Okay, so just our intro slide and the agenda. Okay, how do I move through this? I think you are seeing, am I sharing my notes slide?
Nope,
No.
just the
Nope.
just
Okay.
the regular slides.
All right, well, why can't I get that to move then? Huh. Super. Okay, well, I'll do my best and see if we can. So this is the agenda. We'll just talk about kind of the creation of the PEB and OEB boards, a general overview on our program highlights, partnerships, combined functions, all of that. Our organizational structure, you're going to see that we are a small but mighty team. That's what we like to say. We have about 40 employees and we do a lot of work. So we'll talk about that. Our operations, that's really what I think you want us to focus on. So that's, we'll talk about all those categories, our partnerships with our carriers and also our consultant. I know you had some questions about that. So I have provided some information, a slide specific to that and all the work that they do with us. So the PEB board, Ollie and I were trying to figure out, Ollie's our director, we were trying to figure out exactly when PEB was implemented. We think that it was the late 90s, maybe 96, 97, somewhere in there. It's been around a long time, long before either one of us. Obviously, we provide benefits for state employees, universities, and then we have some local governments too. And we'll talk a little bit about the makeup of the board as we go through this. OEB was, I think, 2008 is when it was implemented and provides similar benefits, although in a different fashion for educational entities, school districts, things like that, also some local governments. Okay, so this is where I really need my notes. Would be super helpful.
And Cindy, if it's easier, we could certainly share because you sent us your PDF. So if that would make your life easier, let's do that.
Fantastic if you could do that, and then I can access. I'd really like to be able to make sure I'm covering everything. So let me stop sharing.
Okay. I will take care of that.
Sorry about that.
1 second. Sorry, everyone. Thanks for hanging with us. Yes, 1 second.
Okay.
You all let me know when I'm there. Okay. Is that where you were, Cindy?
Yes, and I think I'm on the next
And
going, and I'm
one more.
on
There we
that
go.
one
I think
right
that's
there. There you go.
perfect.
Okay.
All right, you just tell me
So-
when to go.
I'll let you know when to move. So this one has a lot of information on it. This is really just the background of the boards. You're going to notice as we go through this that there are similarities between the two, and then there's also some pretty big differences. So the plan years differ. The PEB plans are for a calendar year, so January through December. School districts, OWEB follows the school district school year, so October through September is the plan year. I will say that OWEB did contemplate at one point shifting their plan year, and as you might imagine, the school districts were pretty resistant to that. So that's why we've maintained the two different plan years. The funding models also differ, and I know that this is something that you are very interested in hearing about. I'm going to do my best. Ollie is really the expert on this. So if we have specific questions going back that I can't answer, or maybe Margaret can't answer, then we'll come back with some information. The primary difference between the two is that PEB is mostly self-insured. We're about 80% self-insured, 20% fully insured. So we have a couple carriers that we work with that we are third-party administrators for us. And then we have one fully insured plan, which is the Kaiser plan. So what that means is we take all the risk and the loss if claims are greater than the premiums that we receive, but we also retain surplus if premiums exceed the claims. So in a lot of years, that's been the case, and in some years, it's been more challenging. This year was a pretty challenging year. So in order to self-insure, we have to have 20% of annual premiums to hold in reserve to cover the claims and also claims run out. Let's see. I know one of the questions that you asked, I just wanted to make sure to cover this, is how we were able to self-insure for PEB and not for OWEB. And that, again, Ollie said was long before we got here, but there was a huge settlement with OHSU at one point, and that funded, it was apparently 250 million, maybe. I don't know if that sounds right. And so we were able to self-insure PEB. OWEB, on the other hand, is a fully insured program. They have not, obviously, you have to have a lot of money in order to start with self-insurance. So, oops. Oh, no, I've shifted off. Sorry about that. So they began in 2008. The reserves have been built up, that they being OWEB, the reserves are building up, but they're just not in a solid enough place to self-insure. Ultimately, that will be their goal, but it takes a lot. So I don't know, and I'm not going to be able to tell you very much, but how many questions you have about the budget itself and the funding itself. I can give you very high level about what I've done now, but if you have other questions that you really want us to address, we can do that. Maybe Margaret would be able to answer some of them. I can do my best, but is there anything specific you want to know as far as the funding is concerned for the programs, or can I bring you back information?
Cindy, I think it's really just about, we're the operations committee.
Yeah.
And I think the issue is we're going to have to set up an operational infrastructure for the plan. And what we're looking for is just some examples of how that's set up. So if you could really focus on, how you structure for the self-funded plan in particular, not the fully insured, but for the self-funded, how you set that up and how you operate that would be really helpful to us.
Okay. Hopefully then the rest of the presentation is going to address that, Bruce. And if there's something missing, then you all just let me know and we'll provide it. Okay, so let's go to the next slide then. Actually, maybe we'll stop here for just one more second. So we do have the two boards. Let's just give you that. They're very similar employer contributions. That's where we start to differ. We'll focus on PEB because it is the self-insured or the fully, and I don't know. Our employer contributions are very different. The school districts are closer to what you would call an exchange, similar to the old Cover Oregon Exchange, Marketplace Exchange that we have now. Obviously, with PEB and state plans, we have just a set number of plans. School districts have a variety of plans from which to choose, and the school districts themselves are the employers, so they decide what they're going to contribute to the cost of the plan for employees. Okay, let's move to the next slide. Can you move to the next slide?
Is it not advancing? It should, does it say organizational structure right now? Is that what people are saying?
You're right. Yep, sorry. I'm trying to do too many screens at the same time.
Cindy,
Yeah.
Sarah here. So the words you were saying just now didn't feel like they matched up with the colorful slide that had the circle of OHA in the middle a couple slides back. Was your verbal an explanation of this colorful slide?
No, it was, sorry, I probably had her advance too soon. It was the slide before that slide. This is the slide that I was talking about.
Okay, thank you.
Does that make more sense?
Yes.
Okay, sorry. Again, I'm just trying, technology is not necessarily my strength when I'm trying to have too many things going at the same time. So let me just move this over here. Okay, so this right here, I think is what you're referring to. This is just an illustration of kind of who we work with and how we all work together. So as you can see, we're all part of the Oregon Health Authority, Public Employees Benefit Board. So we have our carrier partners. Both programs have similar carrier partners. PEB has a third one, Providence, but we share MODA and Kaiser. And through the carriers, we have our wellness vendors that they actually contract with, we don't. And then we have we have some committees that we work with. So they differ based on whether it's PEB or OWEB. And this is just kind of an illustration of how we all work together. Margaret is going to potentially cover some information about the innovation work group and the strategies for evidence and outcomes work group, if that's something of interest to you. But we'll just move through and keep it at a high level until you, unless you ask questions. So let's move to the next one. Okay, so these are the primary work groups that PEB and OWEB work together on. The health equity work group, as you can see, it's described here. The joint innovation work group is something that initially started, I think, as a PEB-focused work group and expanded to include OWEB members, OWEB board members. So these are board groups. And conversely, the Strategies on Evidence and Outcomes work group, which we call COW, started out as an OWEB work group and has now expanded to include PEB. Are you interested in more information? Because Margaret can share information about these work groups, or we can move through and cover operations and come back to it if you want.
I think if it's okay, we'll do a little bit more on the operations. So, and then
Okay.
come back if
Yep,
there's time. Thank you.
absolutely. Okay, so this is how we're organized. I will say that when I first started working in PEB and OWEB, we were two distinct entities. There was PEB and there was OWEB, and it was Senate Bill 1067, can't remember the actual year, that the legislature told us we needed to align our programs. So now we have one director for both. We have a deputy director and then myself. I'm the director of operations. I'm not even sure I introduced myself. I'm sorry. And then within that, we have all of these small teams. We really do it all. We have our own financial services team that functions independently. We also have a contracts team, which we'll talk about all of these areas that functions independently, program and policy, as you can see, benefits, communications, and also our systems. So let's move on to the next slide. Okay, this is the financial services team, and this is kind of the process for, I'm not going to go into detail on this, but this is the process for invoicing our carriers and collecting and then invoicing the carriers, and it's circuitous, and we can cover that later if you're more interested, but let's continue on through the operations. Okay, so our benefits and customer service team, I want to say we have maybe 6 people. They do a lot of work. So we have a contact center. They answer phones. Right now they're in the middle of open enrollment for OWEB. So they are on the phone probably 8 hours straight a day. At the same time, they're answering inquiries from members via email. So they're fully member focused. They also work with our entities, specifically on the OWEB side. There's a lot of entity admins, so school district administrators and payroll staff and all of those, because they all have their own payroll centers, and they choose their own plans. They do all of that. There's quite a focus with the customer service team working with that group of people. In addition to that, they review appeals that members may have. They work with a group called Self-Pay Early Retirees, which is pretty much just what it sounds like. And we also have an administrative rules coordinator who does all of the rules and updating for both programs. Okay, dependent eligibility verification. This is pretty new. 2017, state legislature passed a law that said we have to verify all dependents who are enrolled in either one of the plans. So we've been doing that since then. There's a process for doing it, and you can see there are different ways and different groups of eligible, or hopefully all eligible entities. So if we want more information on that, I can sure give you a ton of information on that, but probably not highest on your list. We have a communications staff. There are 3, and we do a ton of communications. We have a monthly newsletter. You'll see this here, learning and events, wellness guide, and also then a new hire video. These are done monthly, just regularly throughout the year. What is not included here is all of the open enrollment communication materials that we send out. It's about 3 months worth of work before open enrollment even starts. So also very self-contained. We have digital education tools, which have been spectacular. We're going to talk about Mercer here in a little while, our consultant, and all the things that they do to help us be successful and get our work done. And one of the things was that they've done is create these tools that members can use as they're trying to make their plan decisions. And obviously we have websites. We have one for, you're seeing PEBs, but we have them for both programs, PEB and OEB. And okay, so the benefit management system, this was another area of interest that you had mentioned. So right now we are in the middle of a replacement project. I will say it hasn't gone super well. We've been working on it for about 5 years, but the bottom line is our current benefit management systems are split. We have one for each. They're pretty antiquated. Their lifespan is not that long. As you can see here, they're Oracle databases, and they're hosted through the data center. The new replacement project that we're working on will be a SaaS solution, which means very little to me, but that's what it is. It's essentially going to be an off-the-shelf product, and we're working on trying to update that so that it's
Sarah had a question for,
yeah.
you had a moment.
Oh,
Cindy.
sure.
No, I'm sorry. That was purely an accident. Don't know how.
That's okay. Well, I was looking forward to answering a question.
Actually, though, while I do
Yeah.
have a question then, are these off-the-shelf products, or are they products that you designed specifically for PEB and OEB?
So the current systems, I cannot tell you about PEB because it's been around for a long time. I believe it was a custom solution. OEB was then kind of mirrored from, or cloned, if you will, from the PEB system and customized some so that it would work for the OEB program. The new solution, however, is supposed to be off the shelf, as little customization as possible. And that's kind of what we're struggling with because we do have such a unique operations, and it's been challenging for the new system vendor. So we're trying to work through some of that.
Thanks.
Yeah. So this is kind of a data flow. I don't know that you necessarily want to go through this, but we do work with various HR systems that provide us eligibility information. So for instance, for the state, that would be our state payroll workday. We do have, I think, about 4 other payroll systems that we work with. Universities have their own. So we're collecting data from them into the benefit management system. And then we maintain the enrollment. So our staff here maintains the enrollment portion of that. So then we have the payroll and carrier system. So we're also working with carriers and sending them information. We send information to the payroll centers and also to the carriers so that they can update the enrollment on their end. And then there's this invoicing payment process, which I will say is not, it's outside of our current benefit system. And one of the things that we are really hoping we can use this new benefit system to help us with, make it a little less manual, but that remains to be seen. It's one of the issues that we're having as we go through. Off-the-shelf products, we've just found just aren't, they're pretty basic, and employee benefits for, especially for state government and the way PEB and OEB do them are pretty complex, and so it's hard to fit them into an off-the-shelf system. So, okay, next. Okay, so I'll talk a little bit about our contracts team. That we have about 3 people that do all of this work. We do have a special procurement authority, so we don't have to go through DAS to do our procurements. So we use the RFP process, if you're familiar with that. We are actually right in the middle of an RFP for PEB right now for new medical carriers or for, new medical carriers. So these are the things that the contracts team does, all the way from designing the RFP itself, and then coordinating all of the other, reviews of the RFP once they come in and all of that. So I can give you a lot more detail on that if you're interested, but let's move to the next slide. And so in addition to that, the contracts team works with the boards once the board makes the decisions on plan changes or for the upcoming year. Then the contracts team goes in and updates the contracts and works on the negotiations, has carriers review it, all of that. And then DOJ provides legal sufficiency. So there's a lot of going back and forth, but it's really, we work independently of DAS and all that work is done within the PEB and OEB team.
Cindy, this is Mimi. Can I ask you a question sort of about the contracting? So if I'm understanding this correctly, some of the contracts that you're talking about are with health plans for
Yes.
the, fully insured. Now, for the self-insured portion of it, do you have a third-party administrator that is contracting directly with providers?
Yes.
Or-
So
Okay, thank you.
yes. So for instance, in PEB, Providence and MODA are both self-insured. And so they are our third-party administrators. They do pretty much everything an insurance company would do, reviewing the claims. They do all the claims adjudication and all of that. It's really that we pay them an administrative fee to do that instead of a premium to do that. So they're doing the same work as for instance, MODA is self-insured for PEB, but fully insured for OEB. And so.
Okay, so, but it is like that third-party administrator for, we'll say MODA, because Providence gets confusing because they're also providers.
Yes.
But MODA will go out and contract with the providers, but still in their role as a third-party administrator. So
Yes.
Thank you. I think that's one of the things that we're interested in for sure.
Yeah, we actually use the same networks that they use for their fully insured business. So yeah.
Thank you.
Sure. Okay. So program and policy, Margaret is our program and policy lead, and they do a ton of work. It's very important, I think, as you're looking at, trying to figure out what to do. The policy staff are incredibly important. If you have questions about what they do, you can see them, listed here. We've kind of highlighted. Margaret works with Glenn Bailey, who is also our legislative person. So he is analyzing all the bills every year and determining impacts on our programs and all of that. Margaret works with all of the boards, as I said earlier, and those work groups. She is actually the staffs the innovation work group. So critical to have policy staff. Okay, performance guarantees. I'm going to let myself off the hook here and let Margaret talk about the performance guarantees since you asked that question, and then I can come back.
Yeah, you bet. Take a breath, Cindy. Thanks, everyone. It's good to be here. I am Margaret Smith Isa. As Cindy mentioned, I am Program and Policy Lead for PEB and OEB. I'm going to go really high level here and talk about performance guarantees. These are very specific to our medical carrier contracts. And Cindy mentioned a little bit about our contracts team and the RFP process. Also to note within that, even when we're not doing an RFP, both OEB and PEB are doing annual renewals on their contracts. So every year we are looking at the contract, we're making updates. That includes updates, revisions, changes to performance guarantees we may have as warranted. Currently in contract, for our medical carriers for both OEB and PEB, we have a 15% of the total annual administrative fees we pay annually at risk for specified measures. And as a general rule of thumb, ballpark, the administrative fee equates to about 5% of the total premium for OEB and PEB plans. So what we're specifically putting at risk for the health plans in contract is 15% of that 5% in terms of magnitude. So again, 95-ish% of the costs are actual claims costs, not admin. And we do strive to look at value-based approaches and other ways to put claims dollars actually at risk and have guarantees on those. That is sort of a different process than what we include in our actual health plan contracts. That is more related to how the health plans, those contracts they write with the providers. We don't directly contract with the provider network. We contract with the health plan who contracts with the providers on our behalf. So that all said, of the 15% of total carrier and TPA administrative fees that we have at risk currently, we have them split across 3 different areas. 5% is at risk for carriers managing annual cost growth in line with the statutory 3.4% cap. So OEB and PEB in statute have an annual cap on plan premium and cost growth, 3.4% annually. So if that is exceeded, the boards have to look at making changes to bring the annual increase down. Changes, can mean several things. There may be efficiencies that you can identify that bring you some savings. There's benefit reductions. And then to some degree, there's the ability to look at reserves as well as using reserves to close the gap. Although there's pros and cons to every approach, and we can certainly share more about that if it's of interest. But 5% are at risk. Carriers agree that they're going to keep that cost growth at 3.4% or better annually, or they owe us fees at risk. We have another 5% at risk for clinical quality performance measures for each health plan. Those are generally HEDIS measures. We do look at them annually and make updates as appropriate so that we are being mindful to not incentivize or place fees at risk on things where performance is really good and everybody's doing fantastic, but really looking at where can we put our dollars at risk on areas where there's opportunity for improvement. And then the third area, we have 5% of those fees at risk for behavioral health access and network adequacy measures. And that area is a newer one that we've added just within the last contract year. Previously, we had 5% on another category of administrative and sort of operational measures. We do every year when we renew contracts, really look at the performance guarantees and strive to evolve them as certain areas of performance maybe are stable and doing well. It doesn't mean we don't continue to monitor those areas of performance, but it does potentially indicate that, like, if a particular area of performance is going really well, maybe you want to put your performance guarantee somewhere else where you could actually drive and incentivize some improvement. So the performance guarantees are not static, but I do think they're a really important component of the relationship with carriers and TPAs. And it's really an opportunity for the programs to put some incentive behind critical areas where you want to ensure that performance is meeting a certain standard or improving. In addition to the specific carrier performance guarantees, and I guess I will say, these are not the only areas that we monitor or have reporting on or evaluate, but these are the areas where we specifically have dollars tied to targets and performance requirements and financial consequences for the carrier if they don't meet the target. So our reporting goes beyond this, but the dollars are focused in these areas. In addition to this, all of our health plans and TPAs contract with various subcontracted program vendors to provide certain benefits. Things like weight management programming, diabetes prevention programming, virtual physical therapy and pain management programs. So there we also work with our carriers and their subcontractors to identify specific performance guarantees that go in the subcontractor contract. Now, that subcontractor is contracted with the health plan, but the costs are typically a pass-through to PEB and OEB. So we participate actively in how performance guarantees are subcontracted for those program vendors, because any guarantees missed or fees return come back to PEB and OEB as a pass-through. And so the specific performance guarantees or metrics we use in those scenarios tend to be really specific to the program goals and objectives. So the guarantees that we establish for a weight management vendor are going to look very different than the metrics and guarantees we establish for, say, a pain management and physical therapy program vendor. So that is kind of another facet of the work we do under performance guarantees. We do also work with our dental, vision, life and disability carriers as well. All of those other vendors on performance guarantees. Again, those look different than they would for a medical plan. And so not going to go into detail about those, but I will pause in case anyone has any questions or anything they'd like to hear more about.
Looks like Lori, you have your hand up.
Lori, yeah, sorry, I was on mute.
Just a couple questions. I'm curious how you interface with such different carriers, thinking, for instance, of Kaiser, which is a very robust, have their own approaches to, how patients move through their system. And then the therapists, for instance, behavioral health folks that may be operating from their home. How all that works out, how that gets figured out. I guess that's handled by your the Providence or MODA folks, but I was just curious about that.
Yeah. So and that's a good question. Yeah, our carriers and TPAs do really manage the provider network for us. So when we establish performance guarantees in our contracts, those are performance guarantees we're placing on the health plans. So if targets are missed, if goals aren't achieved, the health plan is on the hook. Now, health plans in their provider contracts, it sort of follows the logic that downstream in their provider contracts, they would work to try to implement goals or metrics that would help them be successful, and hopefully, what we want is we want to require measures of our health plans that translate into improved outcomes and sustainable cost, better quality care. So the goal is that, like, say, for our clinical quality measures, which I mentioned are typically HEDIS measures, carriers pretty much universally are familiar with those. There are good national benchmarking sources you can look at to help set targets and inform like what is good performance and what should we be benchmarking to. And then the carriers, when they're contracting with providers, to the degree that they are including quality incentives in their contracts, they are generally looking at the quality incentives in the contracts that we have with them for PEB and OEB in terms of the metrics we're focusing on, and incorporating those into their provider quality incentive programs. In that way, that helps try to hope that everybody is working in the same direction in terms of improving performance on these areas that are key. It is an iterative process with our health plans, and we try to work very collaboratively. It's part of what we do in the several subcommittees that Cindy mentioned, the Strategies on Evidence and Outcomes Subcommittee and the Innovation Work Group, because we do try to balance it with concerns around parsimony, not being excessively administratively burdensome in terms of how we set up guarantees and reporting and requirements. All of those conversations are kind of ongoing. I mean, but I think at the end of the day, what we really strive for is having guarantees in our contracts that make it very clear to our carriers that we've identified priority areas and performance thresholds we expect you to meet, and there's a consequence to you as a health plan if you're not meeting them. Does that help give you sort of a sense of the dynamic between, again, for PEB and OEB, our direct relationship is with the health plan and TPA. So a step removed from providers in terms of contracting.
Thanks. It just, thinking about how to have continuity of quality with, different rural, urban
Yeah.
choices and how different providers operate. But thank you.
Yeah, and in terms of like behavioral health specifically and some of that, so we do look at standards that CMS puts forth, DCBS in terms of any network adequacy, and any rules that they promulgate in terms of things like how geo access and what are time and distance standards that are expected. So we really do try to look at best practices out there. And you're right, different systems of care are different. So sometimes there will be situations where, say, a requirement for Kaiser in contract looks a little bit different than it does for, say, a PPO plan. Recognizing that the different systems of care have some different capacities.
Margaret and Cindy, I'm just doing a time check. We wondering how much more you've got. We've got about 5 more minutes or so.
I just have one slide left. So I think we can do it.
All right.
So one of the reasons that, a huge reason that we're able to do all of our operational things within just this small team of 40 people is because we do contract with a consultant. In this instance, it's Mercer. Mercer has been our consulting partner for PEB for, I think, 17 years, and for the last 3 years, OEB also. So this is all of the work that they partner with us on. So they're critical to the renewal process. They provide the actuarial services for us. They negotiate renewals with the carriers, help us determine what plan changes are appropriate and how to minimize the benefit changes that we have to make to stay within the 3.4%. They support our work groups, do legislative impact statements, all of that. I specifically work with not just the health team, is what we call them, to help us evaluate new benefits or, requests from members for certain things, like GLP-1s have been a big thing this year. And Mercer has done a lot of analysis on that and made some recommendations to us. I also work with a communications team. I think they're brilliant. They're just the amount of work that this consultant, I can't emphasize enough how critical having a consultant helping you would be. They've just been invaluable to us. I could at some point provide more information. I just want to ask, are there areas of operations that we didn't cover? We glazed over a lot of it. I guess I want to say it's a self-contained unit out of the Health Policy and Analytics Division, and we do a lot of different things. So anything you want more detail on, we can provide. I think that's it. Did I do it in 5 minutes?
That was great, Cindy. Thanks. Any last questions, Sarah?
I want to know more about everything. And so I'm wondering if there's 50 pages or like somewhere you could send me to learn more about everything.
Absolutely.
I find this really rich and helpful and relevant.
Okay, perfect. I can gladly pull together some more detailed resources for you. And if you just want to have a phone conversation, I'm happy to do that too in a less formal setting, or pull people together. Like if there are system questions, for sure, Barry Burke, who is our systems manager, is the expert on it, and he can really answer all the details. Ollie or Rosie can answer financial questions. So we do have other resources, and I'm really glad to help you and work with you. And I will send you as much information as I can, and you can tell me to stop. So.
Great. Thanks, Cindy. Really appreciate it. And thanks,
Absolutely.
Margaret.
Yeah. Thank you. Thanks for asking us.
Yeah, thanks for
you so
having us.
Bye-bye.
Mimi, would you introduce our Millman guests?
Yes. Sorry, I'm switching my screen around here too. I'm happy to say, I believe on the call, Kate Shadell from Milliman, our consultant group that has just come on board, and Kate is going to be really leading the work with the operations team and all things administrative. Kate, if you, I can't quite see you yet, but there you are. We were just delighted to have you on board. So we'll turn it over to you.
All right, thank you. It's so great to be here. Is everyone able to see that screen slides?
Right now we're just seeing you.
Okay, let me see if that works.
There we come.
There we go.
Okay, let me put this in slideshow. Does that work for everyone?
Perfect.
Okay, great. Thank you so much for having us. I, of course, brought along a whole team of folks to attend the board meeting today, the operations committee meeting. So I'll go ahead and start and introduce our team. So I'm lucky to be able to be joined by John Casey and Stephanie Ross and Caitlin Shoei. I'm Kate Shadle. All of us are part of the healthcare management consulting team. And I don't know that all of them have access to unmute and turn on video. So if we are able to get them that access, that'd be amazing because they are all going to be presenting. And we'll just start with an overview of our total Milliman project scope. If you don't know, or you might have forgot, we are engaged with the whole Department of Consumer and Business Services, UHPGB. We are supporting the design and implementation of the publicly funded Universal Health Plan in the state of Oregon. And so our work really spans a lot of the board and the different committees. We have folks working on the plan design and expenditures, the cost, the benefit package, what that looks like. We've got our team aligning with that work that was mentioned earlier with Eco Northwest, and we'll take over from there and do that assessment of impact to the state. And then our team is going to present and really focus in on that third one, the administrative and operations piece of this, which you all have talked about already. And all of us will come together then to put a final report together by early 2026. And then I just want to focus in next on our team's approach. And, you know, I was not able to be at the July meeting, but I did review the presentation. And Mimi already gracefully did a lot of our background information, but we will start and just share a level set of how our team generally approaches this work. We have reviewed as much content as we've been able to, but we want to just start by engaging with y'all in strategic conversations around the overall goals, the success metrics, how this universal health plan is intending to be rolled out, what the staffing looks like, what the thoughts are about, you know, we've talked about regional plans or one centralized plan. So we just really want to start by having some of those strategic conversations to know more about what your goals are overall. Once we do that, we'll start designing the organizational structure. We'll think about those key leadership positions, what sort of departments will look like, if there is a regional plan in place, how that would impact the organizational structure overall, and what reporting structures will look like. And so we'll work in an iterative way with this board and this committee most likely, so we can give you some examples of what we think is, you know, a proposal. You'll give us feedback. We'll go back to the drawing board and work with that and change that. And then once we sort of have an idea of an organizational structure, we'll start shaping those staffing roles. We'll also think about the technology systems that are needed to support the overall UHP and any other operational demands as we get into more of the details of this universal health plan. And then lastly, we'll develop that administrative costs that go alongside that. We'll think about the startup costs. We know that's really important to all of you, and how that plan is rolled out starting in 2030. And then sort of all of those pieces will come together once we're done. We'll help develop that roadmap and a plan for implementation so that you've got a very clear next steps once everything's set up. Any questions on our overall approach at Milliman?
Keep going, Kate. It's good.
Okay, perfect. Well, I'm actually going to pass it over to my colleague, Stephanie, and she'll take it from here.
Hi, everyone. Great to meet you today. Thank you for having us. As Kate mentioned, I looked through some of your stuff in July, and we understand that you've had a pretty good overview of what health plans do and kind of some of their operational areas. We just wanted to come today to talk a little bit more in detail about how we as Milliman think about that, their admin and tech needs when we think about those different health plans, and then more specifically, how we think about cost controls from an administrative standpoint as well, because as we design this structure, as we kind of build out admin costs, startup costs, we'll be thinking about then, okay, once we are live, how do you think about controlling said cost too? And so we always have that at the forefront during design phase too. So first and foremost, just wanted to throw this out there. When we think about a universal health plan and all of the existing health plans that are likely in Oregon and all of the considerations at play, you kind of have three big buckets of coverage. So you have your government programs, which a lot of you are familiar with, just given kind of Medicare, Medicaid, those payers. Obviously commercial private, thinking about group and individual offerings. You'll see in the next slide some more detail on that stuff. And then also those with no coverage. And so the uninsured and considering that population. And so when we're thinking about this, not only from a structure standpoint of how you're going to operate it, it's also who are all of these populations that are going to be rolling into this plan, and how do you think about that from an operational administrative structure standpoint? So this was just a good visual for us that we were thinking through as we were designing of what all are we rolling into this, and what all do we need to account for, and who are all the existing payers that we need to be thinking about structurally that need to be accounted for. And so in Oregon specifically, I think one of the things to call out. We're looking at roughly 4.2 million people. And then predominantly those in the employer and group space. So that's likely going to be your fully insured and or self-funded if they're larger employers, which all have existing contracts, most likely with commercial payers. And so that conversation of who are your largest payers in your state and who is currently operating and supporting quite a few of the Oregonians will be top of mind for us as we think about structure and recommendation, and then some of the strategic conversations we plan to have with you. And so roughly, this is just what that breakdown looks like in your state. This was 2023 data. You may have more recent or relevant data from 2024 internally, but this is what we were able to pull from our data sources, and just wanted to acknowledge that as we think about this and that previous slide, the payers that are going to be rolling into this, targeted implementation and transition will be critical. And then I believe you saw a high level version of something similar to this last month that talks through the typical process you would expect. But before we got into a little bit more on admin structure and traditional plan operations, we were thinking through what do we need to be considering and what are the most critical kind of quote unquote functions from a member and experience standpoint, right? So how are the members and citizens across the state going to experience this? And those two golden kind of box in areas are where we're thinking from an admin structure and operation standpoint. So how is the plan helping support selecting coverage? Obviously, monthly premiums may or may not be part of this. I know Mimi in our discussions, it's still an exact TBD there, but then how are we also ensuring that they're getting ID cards or whatever that type of indication will look like? Those components will need to be considered for the payer perspective. And then marketing and sales, probably not much on the sales side. John will get more into this in a second, but a decent amount from a marketing and communications and transition standpoint, especially early on before go live, billing, enrollment, processing, all of those things. And then the big piece related to data infrastructure, operational flows around claims and counters and all of the processing that goes into that, not only with normal plans, but especially payers of this volume and size as we think about the population of 4.2 million. So this is just a quick overview of that and how we think about these different things and what we considered as we were thinking through structural things. And so I'm going to pass it over to John to get into a little bit more around the key functions Milliman typically thinks about, how that leads to structural things, and then specifically that cost of care stuff. Any questions for me on a quick overview? All right, John, take it away.
Hi, so I'm John Casey. It's very nice to meet you all. Appreciate you giving us some time here to introduce ourselves and kind of start out here. I have a very long background in administrative cost and operations. And so I spend a lot of time working on administrative efficiencies with payers. And so that's kind of the areas that we're going to focus on is as you develop and we work iteratively with you, like Kate talked about, as we work iteratively with you to kind of create your vision for what this really could look like, we're going to try to keep an eye on how can we find efficiencies? How can we make this, because, you know, if you just take the entire program that Stephanie and Kate gave you a giant, you know, it's a huge thing that you're combining here, of course. We want to find efficiencies in that, of course. You don't want to just cobble together all the pieces that are already there. You want to replace some of them and streamline them and make them more efficient and ideally have some savings there, at least at the administrative level. And so those are the things we're going to be keeping an eye on. And I want to talk through on a few of these slides here. So we can go to the next slide there. So this is how we think about traditional activities of any payer. And I'm not going to dwell on this, but the next slide we're going to talk about, and we can stay here for a second, but the next slide we're going to talk about is how do we think these things might change for you? What administrative activities won't you be doing? Or do we need to have conversations about, that are not going to be an activity for you, or that activity is going to change. And so, most payers, so we do work, and I do work with commercial payers as well. Most of them need to do really 5 things, regardless of the line of business. They have to develop a product. They have to promote that product. They have to service the product. They have to do a good job of servicing the customer. They have to manage the money. So that's conducting financial management. And then they have to manage the risk and technology around that risk. And so they have to manage the technology, which has become a whole bucket in itself to support that business. And so we can go to the next slide. We think that some of these things we're going to want to talk with you, and this is all up for discussion, but would change. So, Stephanie alluded to this, but for instance, well, actually, I'll start at number 1. I won't jump ahead, but product development. You're likely not going to do competitor research activities. These are big activities in most commercial payers that do cost a lot of money, and that's not going to really be much of a thing anymore. Portfolio strategy might still exist at some level, but it may look more like, how do we service different populations versus how do we develop a product portfolio that's competitive against all of the other plans in this geography. Promoting, marketing, and selling. Yeah, you're not going to be selling, but you're going to be shifting more to just communications. And we don't want to make it look like that's all going away. I think some of your marketing activity is really going to become not how do we market this plan, but how do we help engage people. So it's going to turn more into customer service and servicing. Financial management. Payers spend a lot of time looking at how do we price competitively. You are going to need to manage the finances, but not necessarily worry about competition necessarily. And so we think there's going to be things that change, of course, in the administrative functions. And so we're not just looking to roll forward assumptions when we develop pricing for you for this model. We're not looking to just roll forward assumptions about, the current state of how we know payers operate. We're looking for something different, and we want to talk with you about those things. We'll iterate with you on those things, like Kate said, and we'll be asking you to make decisions about what this model will look like. Okay, let's move to the next slide. Oh, and please interrupt me if you have questions. Sorry.
Sarah has a question.
Yeah, are you able
Yes,
to go
please.
back to that prior slide?
Sure.
Yeah, in the promote, market, and sell with every item crossed off there. I'm a nurse, but I'm thinking about providers, and I'm thinking about provider retention in Oregon and maybe provider attraction beyond Oregon. So I hope we can keep in mind that there might be some uncrossouts in the promote, market, sell on an ongoing basis, year after year, or decade after decade, or whatever.
Absolutely. I'm glad you brought that up, because it's one of our concerns is part of the cost of this, and it's not the administrative cost necessarily, but the benefit cost is going to be that you're going to have to maintain a cost competitive environment for providers. And you're also going to have to explain to them how this is a good thing for them, ideally. You're going to need to explain to them that this is hopefully going to make their lives easier. And so we typically, Sarah, just so you're aware, you're right on. We typically put that function in the servicing bucket. When we're talking about payers, we think of that as how do you service the entire plan? How do you administer it? But you are right on that needs to be a key component.
Yeah, Sarah raises a really good point about, a function being, workforce, which is really different from network. I mean, health plans have to develop a network, but they don't focus on a workforce writ large. They don't care whether there's a shortage of gastroenterologists. Just they want to be able to have network adequacy for their plan. So I think there needs to, something about workforce needs to certainly be built into the operations of the universal plan.
Absolutely. I love that perspective. So you're right. Plans typically, yes, they do look at curated networks, but they're looking at how can I build a network that meets minimum state requirements, for time and distance access, which we all know is not really pure adequacy. It's one of the only good ways to measure it, but it's not the real thing. And so, we just recently, and we'll have to bring some of this forward. We just recently had some work we did for the state of South Carolina, which is now public, for their Medicaid program, where they were looking at capacity analysis for the entire statewide workforce and trying to identify gaps. And so that may be something as a methodology that we can bring forward and share with you for you all to consider down the road as a way to look at the workforce. Anything else on this slide? This is a good conversation. Okay. We can always come back. When we think about functions, now this hasn't been adjusted for your future state, but when we think about functions, one of the things that we rely on to build up cost estimates is a set of benchmarks that we maintain. So we maintain a set of national payer benchmarks that we update on an annual basis, and those benchmarks are stratified among these activities. And we will use those as a starting point to estimate costs for different functions. And so what we'll be looking to do is to take these typical benchmark functions for us and to shift them and map them to what your model is as a starting point. There will be parts of the work we can do that we can use benchmarks to help us build it up. So benchmarks that are scalable on a PMPM basis that are scalable. However, there will be some things that you're going to come up with that we don't have a benchmark for that we think is a good one-to-one match. And so in those cases, we'll build up a staffing model and we'll model it out and we'll develop the cost estimates for that. So that's how that'll work. So we're going to do kind of a combination of both things is how we typically approach these. And so we'll end up sharing with you how did we map our functions to our benchmark functions to what you do, and then what fell out of that mapping, and then what did we end up building up costs on. So we'll try to be very transparent there. Okay, we can move on. All right, you all had asked that we bring you some information, some discussion around technology considerations today. So we put together this slide. The major technology, and this kind of, each one of these categories on this slide are the major buckets of technology within typical payers. We think that a lot of these are going to carry forward for you all. So claims processing is obviously huge technology-focused function for payers. It's also one place where you're going to find efficiencies by bulking together all the people and simplifying the programs. Claims processing is one of those areas where you get efficiencies at scale. And so ideally, we'll have a lower cost PMPM in your model than almost any payer that I've ever worked with if we do this right in the end. It really depends on benefit design as well. So if you end up with, I don't know, 150 different benefit designs, that may not be the case. But if you intentionally try to work this in a way that focuses on simplification, which I think is your goal, then I think that there probably are some efficiencies to be achieved there. Provider network and credentialing. This is huge. It's also one area that gets me kind of excited. So provider data is notoriously not clean. And what I mean is that the data that plans have listed on their websites now about available providers and your provider searches, those are notoriously out of date. And to the plan's credit, they get that data from providers. And providers aren't in the business. They're in the business of helping people. They're not in the business of creating data. So it's kind of just a bad situation for everybody. If you can create one single point that aggregates all of that information, you have a real opportunity to cross-check one against data that's being provided from different sources and to be that single point of truth for everybody in the state, which would be really fantastic and special, frankly. That data is, and then you would have be able to give people a much better sense of when are providers really accepting new patients, which providers are actually available, or did they, are they deceased, or did they move, or whatever it is, and they didn't know to update all 8 of their payers, and so those are the kind of challenges that we run into in the market all the time. And so we run into, you may have heard of what are called ghost providers, so providers that are on rosters, but they aren't actually there. or they're not actually providing services. And so I think you have an opportunity to really tackle that head on. But it requires a lot of data aggregation and cleaning. And so that will be a huge lift from this. Currently, health plans, so if you were to contract this service out, for instance, health plans currently don't do all this themselves. They're trying all kinds of different things because they're also being heavily regulated in this space. They're being told they have to get this right. And so they're contracting out to a lot of different vendors as well. And so you may end up in a situation where you end up contracting with a separate vendor to do this. You may decide to build it yourself and work with vendors. And so those will be options that we'll be talking about. Call center, big activity. This one's probably pretty clear to most people, but you're going to have folks answering the phones, and you're going to have to make some decisions about the level of support that you want to provide. Of course, we all want to provide, no wait times and all that kind of stuff. And we want to meet people with all the right languages. But we'd all love to have onshore service, but all those things cost a lot of money. And so you'll have to make some decisions, and we'll help you cost that out and makes it, kind of give you a range of what we think is possible there and the cost ranges for that. But that is a data intensive activity. There's a lot of data that gets generated by call center activity, and they also absorb a lot of data as well in order to service a member in a good way.
John, do you consider case management, care management under that call center?
We do. So we have that really under the data aggregation and reporting systems here. Call center is, it depends on how you structure your care management activities. So if you want to have telephonic care management, and this is something we'll talk with you about, then yes, there's a call center component to that. If you want to try to drive care management into the provider's office, that's a different discussion. But yes, it could be there, Bruce. It also, we look at that as a heavy data aggregation and reporting activity inside the plan so that the clinicians inside the payer entity can be aware of what's going on.
Yeah, I just didn't see those words, so to speak, anywhere.
Yeah, we probably should be a little more clear with you there on that one. So we'll update our list there. But that is a extremely data heavy activity.
Yeah.
Yep. The member portal. So you're going to need to make decisions about how members access data. Right now, most plans have a website, at least. Most have an app. You're probably going to want to replicate those kinds of interactions and decide what's there. And most of them are allowing communication now in that way. Insurance card production and management. This is not huge, but it is something that you're going to have a vendor for and decide an enrollment in your plan. We are very interested to talk with you about that and kind of how you envision that working in the future. Given that, the first thing that popped into my mind is, why wouldn't folks move from Washington to Oregon to get coverage and that kind of thing? And so we'll have to talk about what constitutes enrollment, and is the 4 million number that we originally had up and earlier in our slide, is that really a realistic estimate, or, do we expect population? What do we expect for a true population to be enrolled? Because that affects your economies of scale. Your provider portal, how do you display information to your providers? How do you communicate with them? There are some really great things you can do here. And providers just want it to be simple. And so I think this is a huge opportunity right now. The front desks of provider offices, they have to know 8 logins, and they change all the time, and they have to download information from them all. So if they could do it with one, I think that's great. Data aggregation reporting system. So this is one, I'm going to jump down to the blue box at the bottom, and then we'll move on from this slide, but goes with the data aggregation and reporting systems. You have a huge opportunity, but it's also a big challenge to pull together data from a lot of different sources, including unstructured clinical data. So you have the opportunity, and I know you're all aware of this, to create a true HIE, health information exchange in the state, if you have this single payer system, and kind of break down those barriers there. And so that will be more intense, we think, probably, and more expensive than probably your typical payer in that data and IT space. And so we'll have to have some discussions there about the assumptions we're making in your cost estimates. All right. Any other questions on that other than the good point, Bruce, about medical management? All right, we can move on. All right. So when we go through all of these discussions, we're going to be focused on, well, this is kind of a level setting slide that I really like, but the ways that you impact the cost of care, the ways that you impact the affordability of care, 85% of that is typically in the cost of care. It's in what is contracted with the providers, it's in the benefit design, and it's in the medical management of that care. That is the largest portion of cost in healthcare. 15%, and that's what we're going to be focused on, is the 15%, is tied up in how do you administer it. It's the salaries and benefits that it takes to administer it. It's based on economies of scale, the sourcing decisions you've made, onshore, offshore. Did you build it in-house? Did you contract it out? Do you have automation involved in it? Do you have good processes? So we are going to be focused on that kind of right-hand side of the slide in the work that we're doing here, not that left-hand side. However, we're going to want to get some general guidance from you about that left-hand side of the slide so that we understand what we're going to be administering. And so we'll ask you some questions around that. All right, so I'm actually not going to dwell on this, but you can take this away, but really these are kind of the levers to impact cost. Again, this is that 85% of the cost can be impacted by these levers. So your cost of care, the actual cost of care, benefit design, or medical management of that care. I want to move to the next slide. And again, the point of this is to help you understand what the things that we're going to be asking you a lot of questions in this space and help you understand why we're focusing on these pieces. So these items are the items that really drive administrative cost. The primary one is, and always it has been, and it's going to continue to be for a long time, I think, salaries and benefits. In any given payer operation, 60% of the cost, and this is pretty true for most clients that I've ever had, about 60% of the cost is in labor. It's changed a little bit over the years, but in all, about 60% of the cost is in labor. And so we spend a lot of time focusing there. How do you staff this arrangement is going to be important to what kind of experience does everybody have? And then also, do your members have? And then also, what is the expense for it? Key will be, of course, not overstaffing it and not understaffing it. And so staffing for what is an optimal level of service. And so we can help. What we will do is we'll use our benchmarks and the work that we do with other payers around the country and other state Medicaid programs to help give you an idea of what we think is most appropriate. We'll probably present a lot of options on a range for you, and then you can make a decision about the assumptions that you want to make. Economies of scale, this is one of your biggest opportunities. We already talked about it. I'm not going to dwell on it, but as payer operations get bigger, there are large opportunities for economies of scale. If you build one claims system, it doesn't incrementally cost more and more to continue to process claims. You can just usually pump more claims through it. It's the same for an investment in a medical management system, or you develop one provider network, then you just have to maintain it. So all of those things are kind of baseline costs that if you put a lot of lives into it, it becomes more affordable per life. Sourcing decisions, it is not always more expensive to outsource or to insource. The decision, that basis is kind of customized for every function of a health plan. And so we will talk to you about the options there. You are not going to have to decide in this, at least, exercise in the next month or two, or three, whether or not you want to insource or outsource claims and that kind of stuff. But so we have a broad range of costs there, but we will want to talk to you about that. That's where you're going to need to make decisions, or you might need to make decisions, or the model you may choose is to contract this out to, a payer-like entity that it's going to act like a TPA, and you leave it up to them what to do, as long as they capitate the cost to you, as long as they cap that cost, you let them make that decision. Sourcing decisions, automation. increasingly important these days with AI, which is coming more into play in large health plan activities like claims and customer service. And then process improvements. This is typically, so process improvements is the kind of thing that is, we're going to be, we'll give you some education on this. It's not necessarily going to drive we're going to assume that you're going to have efficient processes with however you do this. But it is a major driver of administrative cost. Okay, let's go to the next slide, which is the last slide. So one of the starting points, and we're going to have a series of conversations, like Kate said, to try to draw all these items out. But one of the first things we want to talk about, and so this is just a preview, is we want to understand what is your intention with the number of entities that with which you want to work. We looked at your previous materials from July, and we know you've talked about, using multiple plans. It didn't seem though like you were 100% decided on that. Maybe it could be one entity that does most of this work. And so that is kind of the next discussion that we'd like to have with you. We see advantages and disadvantages to both of those approaches. And so just to kind of preview that, we would like to start there probably in one of our next discussions with you all. I'm going to stop and see, this is our last piece of material we brought to you today, and then I'll hand it back to Kate. But are there any questions about what we talked about?
Lori.
Yes.
I guess the other very complicated piece, and I don't know exactly how it fits in all this, is pharmacy.
Right.
Medication is control of that element of all this.
Right. So the typical payer, not all of them, but the typical payer contracts with a PBM, and that PBM brings a network of pharmacists and pharmacies, and they also bring a formulary, and they manage the drug utilization. And sometimes the payers will decide to bring in-house some of the decisions related to pharmacy. Typically, lately, it's been decisions related to high-cost specialty medications, things that they think maybe I can manage this better if I hire a dedicated group of clinicians to do reviews or to manage the formulary or to make decisions about those drugs. But that will be one of the key pieces to understand is, we would assume that you would contract with a large PBM to do this work. But we also know that you have entities in your state which have built up pretty significant internal pharmacy operations as well, and networks. And so there may be other options you would consider. So I know that wasn't a real answer to your question, but it's a really good question, I guess, is the answer to your question but typically we would see a contract with a PBM.
Any last final questions? Okay, Kate.
All right. Well, thank you very much for this opportunity to present to you today. We're looking forward to following up and setting up a regular cadence, Mimi, with you and your team. And we'll continue to plan to move forward with next steps and just learning more from all of you.
It was great. Great presentation. We look forward to working with you. Thanks a million.
Same.
You as well. Pleasure to meet you all. Thank you.
With
you,
that, we're going to take a 10-minute break. So why don't we come back at 2:45? See everybody then. Okay. Welcome back. I see Janine is here. Is it Janine just you or is Anya joining you?
I believe Anya was going to join me, but I don't see her, so we can go ahead and
So it's
start.
like just you. So
Yeah, I
we're
guess so. But by default, yes.
we're going to turn things over to Janine, who's going to talk to us about 1331 and 32 waivers.
Yeah. Oh
Take
boy.
it away, Janine.
All right. Hello, Janine Smith from Health Management Associates. We were asked to kind of give a little deeper dive on some waivers that are probably less well known than some of our other waivers that we had talked about a few months ago at this committee. Next slide, please. And just to rehash, what's the fuss about a waiver? You sort of need permission or approval to take federal government dollars, and that's true in Medicare, Medicaid, and in what we are calling advanced premium tax credits and cost sharing reductions, which are available for the insurance marketplace, which was created during the Affordable Care Act passage. So if you want to use if a state wants to use these federal contributions, you need to ask for this permission to do something different. So next slide. So today I was going to focus in on those Affordable Care Act waivers. They were opportunities that were built into the Affordable Care Act, and there's two of them. One's in what's Section 1331, and another one's in the section of the bill of 1332. And they are both allow you to experiment with slightly different activities. So I'll go on to the next slide. So Section 1331 is specifically focused on what's called a basic health plan. Actually, a couple of states really pushed for this to be in the Affordable Care Act, and it allows a state to offer a health benefits coverage plan for low-income people who would have otherwise been able to purchase through the health insurance marketplace, but it allows the state to make that their benefits more affordable than perhaps through the marketplace would be. And it's kind of a bridge for those people who are who are coming because of their financial status, no longer eligible for Medicaid, but not really making a lot of money to be able to afford, say, commercial insurance. So it doesn't really compete with the marketplace, but really replaces it for these certain subset. And the ways they make it more affordable, that a state might contract with insurers at a lower rate than they would as if they were going to contract for other plans on the marketplace. And this lowering of the payment rate will allow them often to offer richer benefits, more similar to when they had been on Medicaid. So it's specifically for people not eligible between a certain income range, 133% and 200% of the federal poverty level. And it's also available for non-citizens who would not be eligible for Medicaid if they fit into a certain income range, but because they're non-citizens, they're not eligible for Medicaid. Only 3 states have a BHP plan currently, and Oregon is one of them. Next slide. So Oregon's is called the Bridge Healthcare Program. It just finally turned on in July of 2024. And it was really designed to help transition people that we had on the Oregon Health Plan during the COVID pandemic. But when you go deeper into their eligibility, they wouldn't have been able to stay on the Oregon Health Plan because of their financial income status. So it was a way to continue coverage, continuity of care for this population. The benefits in the Bridge Plan are the same as the Oregon Health Plan. They do not have cost sharing. Currently there are about 34,000 enrolled, with an anticipation of primarily up to 100,000. and I have the family size and federal poverty level just to remind us all what all those numbers mean. But a family of 4 would be someone who's under making 64,000 or less would qualify to be in this bridge plan, but if they're not eligible for Medicaid. Minnesota and New York also have basic health plans. They started right after the passage of the Affordable Care Act back in 2015 with their plans. So it allowed them to continue, especially in Minnesota, to continue to cover some folks who were at higher incomes than the way their Medicaid program could allow going forward. Next slide. The other type of waiver is 1332. These are called state innovation waivers, and it applies to how a state might want to use or work with their insurance exchange or marketplace. They have to demonstrate that the coverage that whatever they're doing with this waiver is as comprehensive as if a person was on the marketplace plan. There's need to be protections to avoid excessive cost sharing and make sure it's affordable to the same number of people as if there wasn't a waiver. And it provides coverage to many more residents who would be covered, otherwise wouldn't be covered without this waiver. And it's budget neutral or doesn't increase the federal contribution. So there are many ways that states have looked at these. There's primarily one main way, but they potentially can decide how they might want to use the marketplace premium subsidies differently. They might want to adjust the essential health benefits that are required in a plan, maybe augment those benefits, or any sort of enrollment claims data requirements and some of the other marketplace functions and plans. Next slide. And the majority, 20 states, have used the 1332 waivers, and starting back in 2017, that also included Oregon, to stabilize the cost of the plans on the marketplace or stabilize those premiums. 12 states went first, and then another 8 have followed to kind of adjust what's called a risk pool requirements and establish what is a state-based reinsurance program. So it allows for states to modulate the price of the premiums that are offered. It allows the CMS to reimburse the insurers for a percentage of claims over a certain threshold up to a limit. This leads the insurers to price more competitively. So if they know they're not going to have to pay the super high claims, they can offer the overall plan at a lower rate. Oregon's reinsurance program that we've had I think it was around 2017 as well, saved consumers almost 9% on their health insurance premiums on Oregon's marketplace. There have been some states that have used them differently. Some have established what's called a state public option plan. Some have expanded the eligibility for who can be on the marketplace. Some other state-specific premium assistance programs, adjusting the benefits, and direct enrollment and subsidy adjustments. Next slide. And some states have actually used both of these waiver approaches. They can be used in conjunction. New York recently submitted a revised 1332 waiver to raise the eligibility of who could be in their basic health plan that they had under a 1331 from the 200% of poverty level to 250%, and then transitioned their basic health plan under their 1332 waiver. So kind of basically turning off the 1331 and moving it all over and under the permission of 1332. You do have to think about what the interactions, it won't go into a lot of detail, but if a lot of people that are eligible for a basic health plan enroll instead of the marketplace, then there may not be as much available tax credits in the marketplace, and that can increase premium costs for the more moderate income enrollees. Unless the state contributes some money. So you just have, when people are looking at these, they have to adjust them. They also are often used in coordination with the Medicaid waivers. So the 1115 we talked about before, which is for the Medicaid or in our case, Oregon Health Plan, to coordinate some changes. That again, that's kind of what we did with our 1331. I get them confused as well, even though I did this whole slideshow. But on our bridge plan is really to kind of know what's going on in Medicaid, and then what's going on in the marketplace, and are there people falling off in between, and how could we smooth that, and hence the bridge plan was developed. You can't use the 1332 as we are anticipating some Medicaid cuts potentially, but it can be used to improve healthcare affordability and expand access in other areas, which could potentially free up state funds for Medicaid. Next slide. So as you're thinking about waiver authorities, we certainly, as you move into the universal health plan and the discussions in the future here with CMS about it, you will need to look and see where we are at that time with our 1331 and our 1332, and see what would need to be adjusted or modulated, or even could be used to help get the federal dollars in to support the universal health plan. You'd still need to kind of understand and keep track, and especially as this group thinks about its operations, you need to still have some understanding of, like, if there isn't a universal health plan, who would qualify for what, and then how can you use that to pay for the universal health plan. So you'd have to calculate the maximum funding that could be available to Oregon if you didn't have a UHP, the amount of tax credits if you didn't have a UHP, and who's covered, and tracking that in your systems of who would get to be able to understand and pull in the Medicaid dollars, the marketplace premium dollars, and how would the dollars used for the bridge plan. And then you have to think about what happens to the marketplace and its infrastructure, and how could it be used or applied to the universal health plan. It is a source at the moment of people being able to look and pick a plan and get signed up. As Oregon is moving from the federal and moving it into Oregon as own system, the state totally taken over the functions. So just have to think about that whole infrastructure is there. And then what about the reinsurance, and will it be needed? Will you continue the reinsurance program? You have to think about who's carrying risk. How would the state manage this if they don't delegate out to any risk to the regional areas? And then what if you do delegate out to the regional areas? You would need to sort of rethink about reinsurance. So it is a lot of details and nuances. I know that you'll have further discussions about waivers, and Oregon Health Authority is going to continue to partner with the UHPGB governing board to help understand the moving pieces to try to make sense of all this. But it is just another aspect to think about. It's not just what we're doing Medicaid, but it's also what's happening with federal dollars on the health insurance marketplace side as well. And with that, I'll open it up if there's any questions I can attempt to answer. There is a fuller paper that Anya and I put together as a resource for the committee that is part of your materials for today's meeting.
Yeah, the paper was very good, Janine, and I'd recommend it to everybody on the committee if you haven't read it.
It has a lot of resources of if you want to go read more, you really desperately want the intricacies of 1331 and 1332. At the moment, we haven't seen any changes there from the current administration, but we'll need to be continuing to monitor them.
Great, thanks, Janine. So
Thank you.
We're going to move to a discussion. This has come up a couple times in the meeting today about the regions and the central board and the roles of each. And what we're going to need to do as a committee is to really outline what the role and function of regional entities are and what the role and function of the central board are. And so we're going to begin that discussion today. I think just to frame it, the board has really talked about regional entities not taking any risk. So I think for the time being, we're going to not get into the risk conversation, but rather and we're also not going to get into how many regions, 1, 7, 10, 15, 32, what they look like, east, west. We're not going to get into any of that, but we're really just going to talk about what are some of the functions and start to outline some of the functions of regional entities. And today what we're going to do is brainstorm a bit and pick all of your brains as to what you think could be some functions that are best done locally and what are some functions that are best done centrally. So with that, I'm going to turn things over to Lee.
Thank you so much, everyone. I'm Lee Hastings, Senior Policy Advisor for the Governance Board here. And I appreciate you all hanging on with me as I think I'm your last course here. So bear with me. We're going to try to make this interesting. I think it is pretty interesting, and I greatly look forward to your feedback. Moving forward, please. All right, so I think we can all agree there's a lot of benefit to having regional entities, but just to sort of enumerate some of the reasons why this is a conversation that the board is having and that we're bringing to you. We know that having entities that sit a little closer to the ground, closer to the community, can help ensure that the health plan, the healthcare that's being provided is really reflective of local needs and local priorities. We also know that having some amount of decentralization can increase accountability as well, since you have easier ways, more options for being able to engage directly with your consumers of healthcare. When we look at sort of formal evaluations of how hierarchies can work, we really find that there's about 4 levels of involvement when it comes to sort of a central body and then those that are more dispersed. At the most decentralized, we have something where those entities are fully responsible. This is where they would really be implementing every single thing, including finances and even kind of setting that budget, et cetera, and maybe just doing some moderate reporting up to the central office. The next level, we have accountable, and this would be having slightly less authority, but still quite a bit of discretion within their area to implement programs. Below that, we have advisory. This is where they're starting to take a little bit more of a backseat, being able to serve as that conduit from the community up to the central body, but less accountability, less responsibility for actually implementing program features or making decisions. And then finally, at the most centralized, these would be informative bodies where they would pretty much be passing along information, but that would be the extent of their role. Next slide, please. So the Joint Task Force did recommend that regions be a part of a universal health plan. And just to kind of refresh everybody as to what that recommendation looked like, they suggested that these would operate in partnership with the central body. Some responsibilities they indicated would be convening and collaborating with the stakeholders across those regions. Again, doing some of that informative and sort of passing along sentiments of the area into the central body, being able to give voice to those. And really, this last one kind of hits the nail on the head. They really saw regional entities as being advisory. So going up to the board and being able to really advise on some of those policy decisions that are being made related to payment, related to budget, related to reimbursement methodology and other spending decisions. But, advising being pretty much the limit of that. Next slide, please. Now, in the Joint Task Force interim report, they actually lay out quite a detailed sort of distinction, division between what they saw of the public corporation or sort of that central agency versus regional roles here. So I'm actually going to start on the right side. There's these 4 broad categories, and there's just a couple examples of what falls under there. But financial management and stewardship, that would be centralized. That program administration, such as those claims management, customer service functions, quality and data would also live in the central agency under their proposal, and program policy. So looking at what are those covered benefits, what do reimbursement structures look like? Now, when it comes to regions, they articulated 5 kind of specific things. First one is that sort of general, advising the board of the public corporation. The second one is managing a budget, but this is really sort of a limited budget. I think of it as sort of an infrastructure and innovation kind of budget. So having some discretionary funds that they can use to really focus on local priorities. That's, what they envisioned as part of the role. That ongoing community and stakeholder engagement, promoting collaboration across the region and with their sort of neighboring regions, and then engaging in sort of health resource planning processes. Next slide, please. Now, just as a quick example, I know there's a lot of text on here, but wanted to demonstrate that this is really a very common concept when we're looking at universal healthcare systems. And I found that England's integrated care systems and the Danish healthcare system provided really clear examples of how this can be used to have some of those functions that really make sense on a more local level actually be more in the community. So on the NHS side, England uses a system, or I guess it's a system. They call it systems, places, and neighborhoods. And there's kind of different levels of responsibility in each of those, but you'll see things like primary care. It tends to occur more in sort of like a places kind of space, whereas those bigger policy decisions and budgeting does tend to be at the larger system. We see a similar sort of breakout here in Denmark, where they have the state, regions, and municipalities that they're looking at. And the text is pretty small there, but it is fairly interesting. That one goes into some detail about the different types of healthcare services and where authority for those is really located. All right, next slide. And this one, this is kind of a funny aspect of regions that we sort of have been talking around, so I thought it was worth putting an actual slide in here. What actually are we talking about? And there's really 2 options here. We're talking about regions could be part of the public corporation, or they could be these independent third parties, which would be similar to models that we've seen more recently here in Oregon. I listed the pros here, not the cons, because the cons are basically just the reverse of all of these. But as you can see, if we're thinking about regions and these offices as part of the public corporation, there's quite a bit of upside, namely fiscal responsibility. You're not talking about having to maintain duplicative reserves. There's an ability for the public corporation to have full control over finances and returning funds back to the public trust. If there are in fact funds available. There's more transparency, there's long-term stability because there is no need to be engaging in ongoing contracts, and greater accountability to the community. There are some upsides to having independent third parties oversee regions, namely if you really want the ability to manage claims to be at that regional level, And if there's a desire for public corporation to have less direct involvement, staff recommendation is that the work of the regions should be part of the public corporation. And in fact, we consider them sort of regional hubs of the public corporation so that they can feed up most directly and really align with some of the values that we've heard from the board regarding accountability and transparency. As the chair mentioned, we are not going to discuss how many, but a few of the considerations as we've started researching this. The ability of the public corporation to exercise appropriate oversight generally suggests something between 5 and 9. Of course, wanting to ensure that there's adequate population size in order to have some stability in the budget, as well as do good health resource planning for that population, those existing distribution of health resources, considering any natural geographic boundaries, public health infrastructure. And we've heard this one pretty loud and clear from the board, a strong desire to have non-overlapping regions so that they are fully accountable within their zone. Next slide, please. All right, so here's where we really want some discussion and thoughts from all of you on the committee. This is just based on joint task force, as well as thinking about some of those other models, some of the feedback from the board with respect to perhaps wanting the regional hubs to take on a little bit more responsibility. But some of the broad categories that we kind of put out there for you to tell us yay or nay in terms of the central office doing financing and budget, being in charge of policy decisions, engaging in legislative action, payment system design, establishing what covered benefits are, developing what the quality strategy is, setting standards regarding information systems, and doing that data collection and analysis. We then envision the public corporation having kind of on the side those administrative services. We put that to the side since, as discussed before, there's the possibility that that's something that could be contracted out, but feeling that having that centralized would be most cost effective on behalf of the entire state. And then those regional hubs playing a really critical role in developing those provider relationships, especially around primary care, conducting provider education related to quality and cost containment efforts, member enrollment, which I would really see as sort of the outreach to the community, ensuring that everybody knows and can get enrolled in the universal health plan, that community engagement on a public health side as well, partnering with public health and doing that health resource planning. And with that, I leave it open to all of you for discussion and feedback. Thank you.
Yeah, so we'd love to get your feedback as to, are these some of the right things? Would you have different things in there? I'll start by saying the one thing I don't see here that would be important to have regionally is workforce assessment, workforce planning, programs to, attract needed workforce, et cetera. That to me makes a lot of sense to do regionally. And I would, you said it, but I would change the wording on member enrollment to member outreach, because I don't know that you would want to have eligibility confirmation done centrally and member enrollment done regionally. That just doesn't make sense to me. So there are some initial thoughts to get the discussion going. Are there things we're missing? Are there things that you don't think should be there? Would love to get your feedback. Lori.
Yeah, no, I was gonna had the same observation, Bruce, about my concern with having a local focus for provider and and also to promote adequate provider coverage so that we have a high quality plan throughout Oregon, regardless of the resources. So that, and the other piece that comes to my mind is the benefit of a centralized situation is that hospitals in larger areas, Portland, possibly Medford, would become like tertiary centers to help out with the more rural people who wouldn't necessarily have the level of expertise, just like OHSU is often a place where people have to go. So if we have a system where we are giving some control locally, but also holding some control more centrally, I think that could also facilitate that.
Great, thanks. Others? I think as we heard in the previous, the Millman work, there's going to be a tension in some of this between, what is best to do locally and, the benefits of standardization and of economies of scale. And so I think you got to think about that sometimes in terms of how you look at what the functions are. Other thoughts? Sarah?
Yeah, I'm not quite addressing your exact question of what should be and what side, but can I just share some thoughts on centralization in general?
Yeah.
Okay, so I'm 50 years old. Having gone through COVID, I'm used to engaging with some big service provider virtually or on the phone. I'm just thinking of my kids when they're on OHP. When I call OHP for information, I'm perfectly content to be dealing straight with a centralized Oregon entity, and it's never crossed my mind, oh, I wish there was somebody in Lane County where I live, that I could, go into an office or something. So that's personal experience, probably, middle income person, with ease of internet access, ease of picking up the phone. So obviously I can't speak for a wide diversity of people. So that's one thought. And then there was a slide where we were looking at the pros of centralization. I think that was the gentleman in the suit, Stephen from Milliman. Pros of centralization on the right-hand side of our screen, and then on the left-hand side of the screen was like pros of regional entities. And I was kind of hoping that what strikes me without further deep understanding is, yeah, I like all the pros of the centralization, and then somehow having incorporating the pros of strength in regional entities in terms of getting really good engagement and advice from regional entities.
Well, that's really helpful. Other thoughts? Are there things you wouldn't see regionally?
Can I add one more thought?
Yeah.
Third thought that's kind of different. So I think it might have been a whole board committee meeting within the last 3 months or so where they were talking about, was it like earthquake zones or hospital zones? And there were two ways of splitting the state up into like a batch of 9 or 11 or 7 or something. But during that meeting, was congressional districts considered as a way of carving up the state?
I think it was one of the things that was on there.
I just know it fits the bill in terms of like that, was it 6 to 9 regions target with, I think there's 6 congressional districts in Oregon.
Yeah. Are we 6 or are we 7? 6 now. I think we're going to leave the notion of how many to the board itself. There's really only 2 answers to how many. And that's going to be either too many or too few. Anyway, Lori.
I guess
And-
another thing that comes to my mind with the importance of regional input is unhoused people and mental health. Making sure we have an adequate interface with nonprofits in areas where they're key to, especially for equity purpose reasons. I think that would be a hard thing to handle in a centralized format. So you would definitely want to, have the region kind of able to make those personal connections locally.
Yeah, it seems like we need some more description and some more focus on the community engagement line there. I think it sounds like it's kind of buried in there, but we may perhaps need to define better what that can and should be. That's really helpful. Mimi.
Yeah, I just wanted to sort of maybe state the obvious or ask the question if what everyone is talking about kind of, and you can tell I was leading the witness because I put integrated care system on top of this slide. So I think as sort of the folks at Milliman were saying, well, one of the first questions is, would there be sort of like completely discrete regional entities versus a, sort of a more central entity? And although regional work will be happening, it is still part of one system. And I just wanted to sort of see if that's what is in my head, but I wanted to clarify and make sure that that is sort of the sense that this committee has. So I'll just stop there.
Thoughts, comments? Okay, well, we're a quiet group today. Yep. Nan.
Yeah, I actually have a question. When I was in Alaska, we saw patterns of public health prevalence, which seemed to break out pretty cleanly. Cancer in the higher part was higher in some part of the state, and cardiovascular metabolic disorders were higher in a different part of the state. We were using ARIES mapping, right? It wasn't, what we did not see was those public health variations by any political pattern. So I think the community engagement and asset mapping, it's very helpful to have those on a local basis because of the prevalence variations. And one of the prevalence variations that was mentioned already is homelessness and behavioral health and things like that. However, the analysis of that can be centralized. The actual action plans on the ground are better off local.
Yeah, that makes sense. Sarah.
Yes, so if we're kind of getting into the nitty gritty of like proposing edits on this slide, for example, based on what Anne especially just said, I think I'd love to see public health initiatives both in the top half and the bottom half. And so public health initiatives, maybe we call that statewide public health initiatives in the top half. And then in the bottom half, maybe we would call that local variations or local public health initiatives or something like that.
That's really helpful. That sounds great. It doesn't have to be either or. Okay, good feedback. Lee, you got what you needed?
I think so. Anything more, Mimi?
No, I don't think so, other than since we sort of had silence about the integrated care system, I'm just going to go with that unless anyone wants to say, no, I want separate systems. So other than that, we're going to take that as yes, that this has been the vision. Oh, Judy's got her hand up.
I was just going to chime in. Yeah, because in my mind, I'm thinking, sure, so regional entities, folks live in a region, but they don't stay in a region, right? And they cross regions. And so there needs to be some integration because people move around in the state to work or.
Good point. Okay. Do we have anyone signed up for public comment?
We do not have anyone signed up for public comment, but just as an FYI to members of the public listening in, we accept public comment on our website at any time. Public comment can be submitted in a written form, and we ask that people submit those 72 hours in advance of the meeting so that we can prepare, put those online and prepare them. And for spoken public comment during a meeting, we ask that people sign up 24 hours in advance of the meeting. But no signups today.
Okay. Any final reflections or thoughts? Sarah.
Amazing presentations today. It's very satisfying to start like getting into the meat of it.
I agree. All right, good note to end on. Everybody stay cool and we'll see you soon. Take care.